Greetings, aspiring orthopedic clinical specialists. We are going to chat about our knee scenario for the next few minutes. And when we look at scenarios, there's a couple of things that you want to do as you read the scenario. You want to pick out the important pieces. And I'm a paper person, so I like to highlight things. So we're going to go through the scenario, and I'm going to tell you kind of what points I highlighted. As I'm reading a scenario, I'm thinking about what types of questions I might be asked. And they kind of fall into three categories. I'm thinking about examination questions, differential diagnosis, prognosis questions, and intervention questions. So I'm thinking about what information is going to help me answer those types of questions. So when we look at this scenario here, we're given a knee scenario. The first thing we're told, this patient is a 14-year-old female. Whenever we're given an age in this scenario, I always pay attention to the age, because when I hear an age, when I see an age, that can give me certain conditions that I'm thinking of. So if I see a patient is younger, I'm thinking of certain conditions. If a patient is older, I'm thinking of other conditions. And that helps me to start to form my hypothesis in terms of what conditions are more or less likely. So this is a 14-year-old with knee pain. It's also a female. So that helps us, as well as gender may help us think about what condition is more or less likely to be prevalent. So we're told that she came in direct access, so we haven't seen any other professionals at all. We have a large joint effusion, so we start to think about what might be going on. It said that she fell, twisted her knee while jumping on a trampoline, so we know that this was a traumatic injury. She's hesitant to bear weight on her knee, and she refuses to bend it or straighten it. So this is someone that's had a traumatic injury. She doesn't want to put weight on it. She borrowed crutches from her brother, and she's barely able to put her toe on the ground. So she also plays on her travel soccer team. So that's potentially comes into play for a prognosis or maybe a functional activity that might be asked about a little later. So that's the information we're given from this scenario. So I'm thinking it's traumatic, it's swollen, she doesn't want to put weight on it. I'm starting to think of my knee rules about what might be going on here. And that's our first question. In addition to anything suggested by your evaluation based on the report, which first imaging test would be recommended at this time? So for this exam, you do need to know imaging, not specifically what views or what scans are appropriate, but you do need to know MRI, CAT scan, x-rays, which one is better for certain conditions to rule things in, rule things out. But you don't need to know the actual setup of the x-ray, or is it a T1, a T2, a fat suppressed image of the MRI. But you do need to know for certain conditions, is an MRI more appropriate than a CAT scan versus an x-ray. So for this, and that's what this question asks. So which imaging test is appropriate? And we have choices of CAT scan, MRI, no imaging is indicated at this time, or plain film x-ray. Again, it's our knee rules. It's a plain film x-ray. She had a traumatic injury. She can't bear weight on it. She can't move it. We want an x-ray of this. So a plain film x-ray is our most appropriate choice at this time. So then we move on. And our next question, we're asked about strength and range of motion deficits and the effusion being present, the most appropriate intervention at this phase of her rehabilitation. So right at this time, what is most appropriate? We have, actually, you know what I missed? I missed that. I'm going to back up a second. We were given more information. I didn't see that. We were given more information. So this is also important. As we're given more information in a scenario, we want to attend to it. So now we're told that she had an x-ray and it was negative. She comes back to the clinic, and now we have objective information. So now when we're given objective information, we want to be able to attend to it. So now this patient has progressed, and we're given we have stability testing, we have arthrometer results that we were given, and we have some results on some ADLs, some outcome measures that she was given. And she was given an orthopedic surgeon because she's going to undergo an ACL reconstruction based on some of those results. We see that she has an ACL tear. So we're told that she's had the ACL reconstruction, and now she's beginning PT. And in a couple of weeks, we want to decrease the joint effusion and restore quad strength, improve the range of motion, and she's ambulating without crutches. So we're given a lot of information now. We've progressed quite a bit. So now what we're told is we get back to the question. Her strength and her range of motion deficits and effusion, we want to address those, or they've been resolved. So her strength is normal, range of motion is good, and effusion has gone away. Most appropriate treatment at this phase of the rehabilitation. So we've progressed a lot. We've had our initial injury. We figured out it was x-rays were negative. It was an ACL tear, and she's already had the reconstruction, and her range of motion is fine. Her strength is fine. Her effusion is gone. Where are we going now? So that's important to pay attention to, because if we forget that and we think this is still the initial injury, our answer is going to be different. The choices we're given, we have neuromuscular e-stim, NMES, we have perturbation training, plyometrics, and we have balance, static balance training. At this point, our best answer is perturbation training. If her strength and range are normal and her effusion is gone, we want to work on that perturbation training to work on that proprioception and that kinesthetic awareness. NMES is not appropriate because her strength is normal. Plyometrics are a little too advanced, and standing static balance is a little too easy. So we want to be right in that wheelhouse. We want to know our prognosis. We want to know our progressions and what is appropriate at certain stages of rehab. And again, we were given a lot more information here to be able to answer this question. So now we're told that we're seeing the patient 3 days after the ACL and a medial meniscus repair. So we're given her range of motion, and she's had some knee effusion, and we're given quadriceps information, and we're told that she can ambulate as tolerated in a knee immobilizer. So we're taking a step back a little bit. We're told that we had more surgery here. And we're asked, what is the least appropriate exercise during the first 4 weeks? So this is important in this question, least appropriate exercise. So we have to be thinking what's not appropriate at this point after we've had a meniscus repair and an ACL reconstruction. So we're given a lot of choices here, and our most appropriate choice for being least appropriate is a leg press 0 to 45 degrees, because that range of motion doesn't work for a medial meniscus repair in the first few weeks after rehab. Neuromuscular electrical stimulation is absolutely would work. Knee extension from 90 to 45, we're staying away from full extension. That's appropriate. And a straight leg raise is appropriate for quad strength. So that leg press 0 to 45 degrees is the one that is the least appropriate because it puts too much stress on the healing repair. Now we're told that we treat a patient on Wednesday and she reports her knee joint is sore from what we did on Monday, from 2 days ago. After warm-up, her soreness doesn't improve. What's the most appropriate way to modify the program? These are the soreness rules. So we want to know our soreness rules. The correct answer here is to regress the program to the last treatment level. The Delaware soreness rules are in clinical practice guidelines, and they tell us when a patient reports soreness, depending on what caused that soreness or how long it lasted. So did that soreness occur in the warm-up? Did that soreness occur after the activity? Did it occur during the activity? And how quickly it resolved? That tells us what we need to do. Do we need to take a break for a day? Do we need to keep the patient at the same level? Do we need to regress them? And that's exactly what this question is asking. So knowledge of those soreness rules and swelling rules are what is going to allow us to answer that question correctly. So for this knee scenario, there was a lot to unpack. We were given a lot of information, and we were given a progression of information about this is what happened initially. This is what's happening now. This is the surgery that the patient had. This is the surgery that the patient had here. So what we need to do when we have a scenario like this, we need to attend to all that information, and we need to keep timelines straight in our head. Okay, what am I being asked right now? Where are we in the rehab phase so that we can answer questions correctly? So hopefully that helped.